Good evening, sirs. My topic is an elderly COPD patient who has come for an upper abdominal surgery. My patient's name is Mr. Ashogan, who's a 60-year-old male patient hailing from Fort Kochi, and by occupation, he's a mechanic. His complaints are upper abdominal pain, early satiety, loss of appetite, weight loss since 2 months, and vomiting since 1 month. He was apparently normal until 2 months back when he started to experience frequent upper abdominal pain, intermittent in character, burning and intermittent in character. It was aggravated by spicy foods, and it was associated with bloating sensation. He gives a history of early satiety, associated weight loss, and decreased appetite was also present. He has lost 5 kg in the last 2 months. After 1 month, he developed vomiting 2 to 3 episodes per day, mostly in the morning, containing semi-digested food particles. And vomiting was aggravated by food intake and also associated with upper abdominal pain. Past history, the patient gives a history of chronic cough since 8 years with occasional episodes of shortness of breath. Cough and shortness of breath were exacerbated on exposure to cold and dust. Now he has breathlessness on walking uphill, and when walking uphill, he has to stop for his breath. He gets about 6 to 8 episodes of breathlessness per year, and the last exacerbation of breathlessness was 2 months ago. It was associated with cough also. Cough was productive, scanty, white, mucoid, not foul-smelling or not blood-stained. He was hospitalized for the same thrice in the last 1 year. He also has past history of dyslipidemia, no history of childhood asthma, tuberculosis, seizure disorder, no history of any invasive mechanical ventilation in the past, no history of any other significant illness like DM, diabetes, hypertension, coronary artery disease, cerebral vascular accident, thyroid disease, food or drug allergy, no history of any...
Let's summarize the case.
Okay. So he's a 60-year-old male patient, mechanic by profession, with complaints of upper abdominal pain, weight loss, decreased appetite, and vomiting, with also features suggestive of chronic obstructive pulmonary disease, diagnosed as a case of carcinoma stomach, posted for total gastrectomy.
Okay, the patient is coming to you for PAC. Just tell us what are the relevant points you want to see in the respiratory system, which helps you in your anesthesia.
Okay, so first of all, sir, history. In the history, there will be a history of physical examination. Physical examination, general examination, there will be clubbing. Then in the vitals, there can be increased respiratory rate. Then coming to the systemic examination, respiratory system, the patient may have a barrel-shaped chest. The chest expansion may be decreased. The breath sounds can be decreased. Vocal fremitus, vocal resonance, etc. can be decreased. Then there can be sometimes wheeze associated with it. Also sometimes crepitations may also be present. In
the general examination, you said patient, you looked at the clubbing as well as some tachypnea will be there in the patient.
Yes, sir, yes.
Anything else would help you? Is the nutritional status important to you? Suppose the patient has got edema in the legs, face or something.
Yes, sir. Hypoalbuminemia is important.
How is it important?
Because if there is hypoalbuminemia, there is an increased
Why should hypoalbuminemia occur in these patients?
Because of
COPD patients generally have poor nutritional status,
poor
isn't
nutritional
it?
intake. Okay,
Okay.
sir.
Sir?
You said COPD.
Yes, sir.
Why did you come to that conclusion that it is COPD? You said breathlessness, 6 or 7 episodes in a year or something like that.
Yes, sir.
How did you come to the conclusion that it is COPD? Any other history? Is a chronic smoker or something
Yes, sir.
like that?
He was a chronic smoker since the age of 25 years. Now it's approximately 35 years of smoking. So smoking is one of the most common risk factor for chronic obstructive pulmonary disease. So that is one of the most important clue to the diagnosis of chronic obstructive pulmonary disease.
Yeah, you didn't tell about smoking. That's why I wanted to know whether this breathlessness is because of cardiac or because of the respiratory system itself.
Okay,
so you have to mention very clearly the history which takes you towards
the
respiratory.
Okay.
Okay, so this is a case of COPD coming for carcinoma stomach. You
Stomach
said
for total
for total
gastrectomy.
gastrectomy.
Oh.
Okay. Now, how will you investigate this case?
We will first look for the complete blood count. We will check for the hemoglobin to look if there is anemia or polycythemia.
Tell us what is the reason why you want hemoglobin. Give us the reason why you want hemoglobin. Like that, each investigation you have to give a reason.
Yes.
Why you're doing that investigation.
Yes, sir. Sir, we'll check for the hemoglobin to look if the patient is having anemia, which can be a result of nutritional deficiency, or if he has polycythemia, as emphysema patients, because of chronic hypoxia, they are prone for high hemoglobin. Then we'll check for the total blood count. If a patient is having an acute infective exacerbation of COPD, the total white blood cell count will be raised. Then we will check for the renal function test to look for the baseline creatinine, and we'll check for the liver function test.
Why you want to know the renal function test?
Sir, in emphysematous patients with polycythemia,
there can be increased blood viscosity due to polycythemia, which can impair the perfusion. So the renal perfusion may get affected and compromise renal functions.
I didn't get it. Impaired perfusion?
Impaired perfusion, which can affect the renal perfusion.
Okay, so you are looking at a primary kidney disease because of the polycythemia. Okay. Any other reason? Anything else you want to know?
So if the patient has
fine.
any other
any other so primary kidney disease can be there because of the polycythemia. Agreed. Next. What else you want to investigate? Carry on.
So for the serum sodium and serum potassium levels, patients who are taking diuretics in case of core pulmonale, then the serum sodium can be low, and serum potassium levels can also be low. In case the patient is using salbutamol, then there can be hypokalemia. Then we will look for an ECG. And in ECG, we can find a right axis deviation and right ventricular hypertrophy changes, and there can also be PEEP pulmonale, that is tall P waves. Then we will look for a chest X-ray. In chest X-ray, there will be horizontally placed ribs with hyperinflated picture in case of emphysema, and flat diaphragm. There can be a tubular heart. And also, if there is a presence of bulla can be seen, then we'll look for the pulmonary function test.
When do you say that chest is emphysematous?
So if the intercostal space is more than 7, then 8.
9, sir.
9.
Probably more than 9,
9,
you called as an emphysematous chest. Okay.
So then we will look for the pulmonary function test. Then we'll look for an echocardiograph.
Explain pulmonary function test.
Sir, bedside pulmonary function test. We will ask the patient for breath holding time. That is, ask the patient to take deep breath, and if the patient is able to hold his breath more than 40, then it is normal. If it is between 20 to 40, then it is an implication of poor cardiopulmonary reserve. If it is less than 20, it is poor cardiopulmonary reserve. Then we will ask for the cough test. Ask the patient to take.
You have to tell the names of the scientists and after whom these tests are made. Breath holding after whose
breath count.
Breath holding.
You need to tell that.
Okay, sir.
Yeah.
Green and Barrow-Witt's cough test. Green and Barrow-Witt's cough test.
Ask the patient to take a deep inspiration and ask him to cough once. If the test is positive, when there is persistent coughing, recurrent coughing after the first cough, then there is a wheeze test. Ask the patient to take 5 deep inspirations and expiration, and place the stethoscope behind between the two shoulder blades. And if there's presence of wheeze, then we'll check for the forced expiratory time. Ask the patient to take deep breath and exhale as maximally and rapidly as possible. If it is more than 6 seconds, it is an indication of obstructive airway disease. Then there is a single breath count time. Ask the patient to take a deep breath and count from 1 onwards. If it is more than normal patient can count till more than 50, but if the patient is able to count less than 15, then it is an implication of poor vital capacity. Then there is Snyder's match test.
Where a lighted candle is kept in front of the patient at varying distances, that is 3 inches, 6 inches, and 9 inches. If the patient is asked to blow with the mouth open without pursing his lips, and if he can do it at 3 inches, then his maximum breathing capacity is 50 liters per minute. If at 6 inches, 100, and 9 inches, 150 liters per minute. Then there is a maximum laryngeal height. That is where we measure the length from the thyroid.
Would you like to go for a pulmonary function test also for this patient?
Yes,
He's
sir.
undergoing a major surgery.
Yes, sir. Pulmonary function
Before
test.
you go into that, let me tell you, why are you doing all these tests?
We need to know, we need to first of all know the disease, that is whether it is an obstructive disease, restrictive disease, the severity of chronic obstructive pulmonary disease, the cardiopulmonary reserve of the patient, etc.
No, why do you want to know all these things? Does it have an implication?
Yes,
To
but
assess
to
for the
assess the
post-operative
post-operative pulmonary
pulmonary
complications.
Post-operative pulmonary complications. So, you want to do a pulmonary function test? Tell us what is most relevant in this.
FEV1 by FVC.
Can you classify the severity of COPD?
Yes,
Based on the
gold
gold
classification. That is global assessment criteria for chronic obstructive pulmonary disease. Where we
FEV1 by FVC is less than 0.7, and in a mild, that is there is FEV1 less than more than 80%. In a moderate, the FEV1 is between 50 to 80%. It is severe when FEV1 is between 30 to 50%, and less than 30% if it is very severe.
Good. Now, tell me, what are the 2 characteristic features of COPD?
one of the major characteristics is persistent airflow limitation. That is one of the major characteristics. Then it is progressive, airway responsiveness.
Parenchyma?
Yes, sir. In asthma, there is no parenchymal involvement. That is how we differentiate between a COPD and an asthma. In COPD, there is involvement of the airways as well as the parenchyma. There is parenchymal loss of parenchymal attachments and
its elasticity
loss of elastic
and
recoil.
communication with the smaller airways associated with small airway obstruction. So, how do you differentiate asthma from COPD?
Asthma, we can look into the history first of all. That is, asthma usually begins from childhood, whereas COPD usually the onset is from middle age onwards. Then COPD, it is mostly neutrophilic cause. The other one is mainly eosinophilic predomination. Then one is that is COPD is CD8 involved. The other one is asthma CD4 involvement. Then COPD is largely irreversible, whereas asthma is largely reversible. Then
asthma is episodic, while in COPD patients, the symptoms are present throughout.
Diurnal
and
variation.
progressive. Then the parenchyma is affected in COPD, while in asthma only the airways are affected.
So you said this patient is having difficulty in walking uphill or something.
Yes,
you
sir.
said. How do you classify the severity
There
of
is
dyspnea?
a classification which is called as Modified Medical Research Council classification for dyspnea, where the dyspnea is graded from 0 to 3. 0 means he gets dyspnea only with strenuous exercise. 1 means he gets dyspnea on walking uphill or hurrying on the level ground. 2 means he is walking slower than the peers of his age. Then 3 means like uphill itself, he's cannot walk more than 100 meters or more than a few minutes. And 4 means he's unable to leave the house because of breathlessness. It is very difficult to dress and even undress himself.
Okay. Now you have said all the investigations. Would you like to go in for an echo, or when will you like to ask for an echocardiography, and what is the information that you want to gain from that?
COPD, sometimes they can be the involvement of the right side of the heart due to a chronic hypoxia. They can be pulmonary arterial hypertension. So that can cause a strain to the right side of the heart. They can be right ventricular hypertrophy. We can look into the echo. Clinical examination itself, we can look into any signs of right heart failure like raised GVP, JVP, then tender hepatomegaly, then epigastric pulsations, bilateral pedal edema. Then echo findings, they can be the features of pulmonary arterial hypertension. That is, there can be tricuspid regurgitation and tricuspid jet.
Information that you want to gain from what the important information that you want to gain through your echo? You want to know what is the PA pressure?
Yes, sir.
You want to know the condition of the right ventricle, whether it is dilated or hypertrophied, RI size. Can the left side be affected?
Yes, sir. Right.
Oh.
In case of a patient with underlying cardiac illness, then the left ventricle can also be affected, sir.
If there's an associated ischemic heart disease. One interesting question. Can these patients develop pulmonary edema? COPD patients?
No,
No,
sir.
sir. Because of the pulmonary arterial hypertension is very unlikely to develop a
So what does
pulmonary
it
edema.
mean when you have pulmonary hypertension? You said patient was having breathlessness when he walks, isn't it? So what does it mean? What is happening? It could be pulmonary edema also, no?
So pulmonary edema is very unlikely because of the pulmonary arterial hypertension. Pulmonary edema is mainly due to the involvement of the left side of the heart when there is pulmonary venous congestion and extravasation of fluid into the extravascular space.
Okay, here what happens? What is the reason for the breathlessness? What is causing the breathlessness? It's right heart failure. Your right ventricle is failing. That's why you feel breathless. Understand?
Okay.
Okay. Now, what is the plan for this? Anything else in the preoperative?
Yeah, before you go for your anesthetic plan, how do you optimize this case? Here is a case who has got cough and breathlessness for the last so many days. So how do you optimize your case of COPD?
So first of all, we'll ask the patient to quit smoking if he's a current smoker. Then we will ask the patient to continue his own inhale.
Before you go forward, you ask the patient to stop smoking.
Yes.
How many days you want him to stop smoking?
Sir,
Effects of various stages, tell me.
sir, minimum 8 weeks, sir, to stop smoking. The effects of smoking in the respiratory system, cigarette smoke contains celotoxin, so the tracheobronchial clearance can be affected. Then also there will be surfactant reduced, so there will be loss of elastic recoil. So the pulmonary compliance will be reduced. Then in cardiovascular system, it stimulates the adrenal medulla to release adrenaline. There will be rise in heart rate, BP, peripheral vascular resistance, systolic, diastolic BP will be raised. Then there will be a shift of the oxygen hemoglobin dissociation curve to the left. There will be chronic hypoxia, and it also procoagulant effect will be there because of increased fibrinogen activity. So thromboembolic condition will be raised incidence of coronary artery disease.
This comes as an urgent case. Urgent case.
Okay, sir.
How many hours you want the patient off smoking, and how does it help?
72 hours, sir.
72 hours. How does it help?
Because in the first 12 to 24 hours, this carboxyhemoglobin level starts to decrease, and the nicotine also starts to decrease. Nicotine is a airway irritant. It can cause bronchoconstriction. In the 72 hours, actually, this carboxyhemoglobin level normalizes, and the ciliary function also improves. So a minimum of 72 hours is actually required if it is an emergency case. But that will cause the shift of ODC to right and increased oxygen delivery to the tissues.
How much time do we have? 10 minutes. Huh? Okay. Shall we go to? Okay. What is the anesthesia plan for this patient?
So plan is it's a total gastrectomy case. So plan is general anesthesia with controlled ventilation with endotracheal intubation with thoracic epidural and analgesia.
Suppose you have a case, for example, you got a ventral hernia, umbilical hernia.
Okay, sir.
And I am suggesting to you that why not do this case under epidural or a slightly higher spinal? Would you agree to that?
Since already it's a compromised ventilatory function, this epidural can again cause, if the level is high, that is above T6, the sensation can be decreased. That can again compromise the ventilatory function. So more chance of post-op pulmonary complications.
No, how does it compromise ventilation?
Because the intercostal muscles can get affected. Upper abdominal muscles relax, so the patient can more prone for respiratory distress. So.
Yes, because the rectus muscle will be actively involved in breathing out.
Okay.
So when you paralyze those muscles, patient will have severe respiratory compromise. So epidural or spinal anesthesia is not a good choice for upper abdominal surgery. You can give it for umbilical hernia or something like that, but not for upper abdominal surgery. So if you're planning for general anesthesia, what are the things you would like to take care?
First of all, we need to optimize.
Let me start off from the ward. You have seen your PAC, cleared the patient, taken consent, all those risks and all has been explained to the patient. You would like to transfer the patient, on the night or the morning of surgery, would you like some pre-medication for him?
Yes, in order to decrease his anxiety, a low dose of benzodiazepine can be given to this patient. That is, we can give alprazolam 0.25 milligram on the night prior to surgery at 10 p.m. or so. Then we can also, since smoking also have effects on GIT, that is, it decreases the tone of the lower esophageal sphincter, increased chance of reflux. We can also give pantoprazole proton pump inhibitor on the night prior to surgery, as well as a prokinetic agent, metoclopramide 10 milligram prior to surgery, and also on the morning of surgery.
See, nowadays we believe in not keeping the patient's NPO.
Yes.
Isn't it? How long would you like to give your NPO status? I would like to know.
So since this is like a full stomach case, NPO 8 hours for solids is what I prefer. And try to avoid clear liquids prior to surgery since it is a full stomach case. Instead, in order to avoid dehydration, I would prefer to put an IV line, secure a peripheral IV line, and start IV fluids at maintenance doses in order to avoid dehydration.
What are the problems of dehydration in this patient?
So
I do not fully agree with you, but I agree with you also. But what are the problems? If you dehydrate this patient, what are the problems?
So the blood viscosity will rise. So already the patient is having polycythemia. So the chances of thromboembolic conditions, especially post-op, can be added on.
Okay, let us imagine this patient is very, severely COPD patient. You're transferring the patient from the ward to the receiving area. The surgeon says, okay, let us give him some oxygen when you transfer the patient. Would you agree?
So I would prefer not to use oxygen since this patient is chronically hypercapnic and he's already dependent on this hypoxic drive for his spontaneous respiration. So that can be lost when we give this oxygen while transporting.
So you want to keep, would you like to use a pulse oximeter?
Yes,
while
sir.
transporting?
Yes, sir. Pulse oximeter and try to maintain a saturation of 88 to 92 to 94.
What would be the normal saturation of these patients?
Normal saturation from 88 onwards
80
to
to 90. So keep it. If at all you want it, titrate your oxygen when you transfer the patient, because you are not there to transfer the patient. Okay. Now patient comes to the theater. Tell us what you want to do.
So I would, before shifting the patient, I would check the machine, keep all the necessary emergency drugs, anesthetic drugs, then infusion pumps, then fluid warmers, body warmers. Then I will shift the patient, attach the monitors, standard ASA monitors, that is ECG, blood pressure, non-invasive blood pressure, and pulse oximetry. Then I would try to use a rapid sequence induction. That is, first I will explain to the patient that as soon as he starts losing consciousness, a small pressure will be applied onto the front of his neck. I will also keep a trained assistant ready to do this maneuver. And I will pre-oxygenate the patient and I will give a anxiolytic, that is midazolam, in a dose of 0.02 milligram per kg. Then in order to decrease the stress response, I would give an opioid, preferably fentanyl, in a dose of 2 microgram per kg. Then start inducing, that is propofol. I would like to prefer propofol for induction in a dose
Please
of...
tell me why you prefer each of these drugs. Okay. Why propofol? Why not thio or etomidate or ketamine?
Okay, sir. Ketamine, if we use, there is an increased chance of secretions. So it is better to avoid, since there are already chances of bronchospasm when the patient is having in the light plane associated with secretions, etc. So it is better to avoid ketamine, even though it is it has also positive points like bronchodilation. Then propofol, we get better suppression of the airway reflexes. Then it's also a bronchodilator. Then thio, the airway reflexes are not that much suppressed, so more chances of bronchospasm, laryngospasm, etc.
So which muscle relaxant would you prefer to use?
For rapid sequence induction, I would use scoline in a dose of 2 milligram per kg, and after that we can use vecuronium in a dose of 0.1 milligram per kg. Better to avoid etracurium, since it can cause histamine release, bronchospasm.
What measures will you take to prevent bronchospasm now when you intubate?
So we can deepen the plane of anesthesia by using propofol. Then we can give to reduce the stress response. We can use intravenous lignocaine. Then we can use salbutamol, sir, 2 puffs. Then we can
Magnesium infusion?
Yes, sir, magnesium infusion. Then Estalin puffs.
Okay, you have intubated the patient. Okay, tell me your ventilator settings.
Ventilator, it is better to use volume guaranteed pressure control ventilation.
Reason for that?
So if we use volume control ventilation, there is a chance of increase of airway pressures, that is peak pressures, plateau pressures, etc. can arise. If there are any bulla, that can cause rupture of the bulla and can cause pneumothorax. Then even if we use pressure control ventilation, again the volume need not be delivered, so it is better to use a volume guaranteed pressure control ventilation.
What are your settings?
Settings, so a tidal volume 4 to 6 ml per kg, then a PEEP of 5 to 8 centimeters of water, then adjust IE inspiratory to expiratory ratio of 2.5 to 3.
Okay, what is auto-PEEP?
Auto-PEEP is actually these patients, their expiration is actually terminated before the alveolar pressure decreases to the atmospheric pressure. So the end lung volume will be increased. because of the increased resistance, work of breathing, etc. And it can cause, again, a dynamic hyperinflation, and that can cause the generation of auto PEEP.
So external PEEP is useful in these patients or
Yes, sir. External PEEP is always, it's better to use external PEEP because it will keep the small airways open. It won't be collapsed. So, this air trapping can be
lesser?
lesser.
Okay. How much time we have?
Sir, actually the time is over.
Over. Okay. What is your pain? Just
Last one. How will you calculate the fluids for this patient? What fluid you want to give? How will you give?
So, restrictive fluid therapy is what I would prefer, since I would like to extubate the patient at the end of surgery and avoid lung congestion. It is better to use a fluid calculation can be based on the goal-directed fluid therapy based on the dynamic indices such as pulse pressure variation, stroke volume variation, etc. Or CVP also, since there is no.
in fact, I
right
just
side.
want to add last final thing. There's a recent article which is meta-analysis which just looked at all these things and they found 3 things. One is low tidal volume. Second is restricted fluid therapy during the perioperative period. And third thing is use of Sugamadex is associated with significantly reduction. I mean, multivariate analysis, these are 3 factors during anesthesia that has been associated with the reduction in the post-operative pulmonary complications. Thank you very much. You have done well.
Thank you, sir.